So next we have iGlarLixi, a solid approach for comprehensive diabetes management by Dr. Krishna Seshadri, who requires no introduction. He is a consultant endocrinologist from Chennai. He is a principal investigator in several multicentric studies and is a prominent figure in the medical education. Over to you, sir.
Thank you very much. I feel like a schoolboy because when you come up last and you still find people in the audience, then you're reminded of the times when you have spoken to 3 or 4 people. But even if one person is there, and now we have Anuj also sitting here, it's still a pleasure to be here. So first is thank you. I won't keep you away from lunch. I won't talk to you about landmark. You've heard this again and again and again. Let's talk about something very interesting. It is Nock who first said that insulin and GLP-1 RAs were made for each other. I remember this fantastic editorial that came many, many years ago that talked about the marriage between insulin and GLP-1 RAs. The reason was, at that time when the first study came that combined insulin with the GLP-1 RA, this is by U. Naik et al., it showed something very interesting. First, the dose of insulin came down. Second, those who were taking multiple doses, it started coming down to simple, either once or twice a dose. Second, even in those patients, the amount of insulin used came down. Fourth, the weight came down. So this was something that sort of revolutionized this whole thing, because until that time, the big issue with insulin was what? Weight gain. Second, higher doses, and of course, non-compliance. So when this particular piece of information came, we realized that these work very, very well together, right? So the simple way that things do is that you combine 2 drugs that complement each other. Insulin, of course, is the cornerstone of therapy. GLP-1 RA is a way to make insulin better. One, greater prandial control, because basal insulin is something that's fantastic. On top of that, you add a GLP-1 RA, it makes a lot of sense. In this whole thing about long-acting GLP-1 RAs, we forget the simple way of how to bring these 2 together. So one is, why is it useful? One, if you combine them, you address the pathophysiology, you give it convenience. Second, it becomes easier to titrate, lowers side effects, lower hypoglycemia, and therefore improvement, right? So this is really this balance between GLP-1 RA and insulin working well together. Now the question is, can they work together in the same vial? If that happens, life becomes even more easier. We'll talk about it. So the first person to do that was Novo, but for some reason their interest in this went away. But Sanofi has done this, and what does it do? Put GLP-1 RA and insulin in a single vial. Both separate, work together, get the glucoses down, but do not push the sugars up, and therefore makes life easier. And they still continue to be in the regimen. So one of the first things that we do now is either it's a GLP-1 RA first, or insulin followed by a GLP-1 RA before we even talk about prandial insulins. And this is something that the guidelines are also talking about. Is there evidence to support it? Multiple. So this is on suboptimally controlled OADs, on basal insulin, on those uncontrolled by GLP-1 RAs, and those on premixed insulin. So this thing is quite high. Just give an example of one patient, diabetic, multiple OADs, A1C is 8.5, what happens? So the big question is, should I start with just basal insulin, or should I use a combination of both, or a GLP-1 RA? Now you could do all 3. But one of the smart things is, if you see both the fasting as well as the postprandial elevated, then combining these 2 insulins, a basal insulin plus a GLP-1 RA, makes fantastic sense. So here's data comparing iGlarLixi with IDEG-ASP, which is a good combination. And in India, IDEG-ASP has been a very good combination simply because the majority of our patients have prandial glucose increase. And a simple guide is, when do you use a combination that has prandial insulin? When the difference between fasting and postprandial is more than 80. Now, in the same group of patients, can you just use a combination of glargine plus lixisenatide, which is the GLP-1RA? So it's very simple. This is the data. This is 50, average age is 56 years, 48% female, not very obese, more Indian-like patients, long duration of diabetes and A1C over 8.5. Most of these are on SGLT2 inhibitors and metformin. And this is superiority. It's not non-inferiority, it's superiority, where a GLP-1RA, when combined with glargine, is superior to IDEC-ASP in the A1C reduction. Not surprising at all, because this is what GLP-1RAs do. GLP-1RAs have greater reductions in A1C, and when combined with insulin, they reduce postprandial glucose, and that's why it is superior. Second, this is the body weight. Big difference. Normally when you add a prandial insulin, your weight goes up. Here the weight has not gone up. Minor reduction in weight. This is the second one. Third, of course, remember when I said when you combine, this is what happens? So weight doesn't go up. Third that happens, the insulin dose comes down. So instead of 2 doses, you could have a single dose of everyday iGlarLixi at the largest meal. Weight will not go up, works beautifully, and then also the dose comes down. The key secondary endpoints, A1C was much lower, less than 7 in 72% of patients. And again, this is something very interesting. In any insulin study, you will never find more than 50% of patients reaching an A1C greater than 7 over a period of time. On the other hand, the moment a GLP-1RA comes in, a large percentage of patients have an A1C that is less than 7. Second, without body weight gain, no, it's a low-hanging fruit, and no hypoglycemia, simply because the GLP-1RA, along with a basal insulin, reduces hypoglycemia. The moment you have prandial insulin, hypoglycemia goes up. Very simple. So again, any hypoglycemia, level 1, level 2, so there's a 29% reduction in hypoglycemia. And remember, this is statistically significant. The RR is less than 0.1. All right. So very interesting study. The SOLI-D study showed statistically superiority of HbA1c, superior body weight benefit, more patients achieving composite endpoints, lower hyperglycemic risk. Simple things, right? So again, this is all right. I have patients who are on premixes. There are 2 or 3 doses of premixes. Can I do something? So let's look at this group. iGlarLixi once daily versus BiASP, which is a premixed insulin, twice daily. Let's see what happens. Same group of patients, and see what happens at the end of it. Many of your patients, especially who are on medium doses of twice a day insulin, can easily be switched to a combination of a GLP-1RA plus a basal insulin. Does it make sense to you? So it's superior to biaspin, both the glucoses, in terms of both, again, non-inferiority as well as superiority, right? The second is that the body weight did not go up, which is something, again, whenever you have prandial insulin, the body weight will go up. Then a greater amount of patients achieving an A1C of 42. This is less than 7%, and this is with hypoglycemia. So clearly the combination and all the things that I said in the beginning, lower doses, lower hypoglycemia, be able to reduce the number of doses and lower side effects. So a simple way is, instead of thinking of adding a prandial insulin, you can always start off with a fixed dose combination of these this thing. And the advantage, of course, is the price today. It's pretty much the same as IDEC-ASP. Same thing. I won't get into time on this. So how do you use it? This is the pen. It's a 2:1. I generally start at 10 units and keep up titrating. The same, I don't know if you saw the Delphi consensus that Manoj Chawla showed. If you notice that my name is on that, we actually, before that, most of us were doing complex algorithms. We all sat in one room and said, let's do +2 - 2. It is much easier for the Indian population. And for some reason that has caught on. And everywhere you will see this +2, -2. Same here. I start the patient, largest meal, tell them once in 2 to 3 days, check your sugars. If it is less than 100, leave it. More than 100, +2. More than 100, another +2, +2, +2. So they can go up to, when I start the patient on 12 to 14 units, when they come back by the end of the month, they're on 20, 22 units. You can go up to 30, 40 units. Works beautifully. You don't give it twice a day, it doesn't work. Right? Simple, +2, -2. The simplest way to treat. Before that, I remember so many articles that came out with these complex regimen. But I remember meeting Sunil, myself, Unni, I think Manoj was there, a whole bunch of other people were there. We started this +2, -2 business. Can you use it in older patients? Absolutely. GLP-1RAs work very well. Can be used in renal impairment. It's not recommended less than 30 as a product insert, but generally GLP-1RAs are quite safe in renal impairment. Hepatic impairment, there is no dose adjustment required. Do not use it in pregnancy. Any GLP-1RAs must be stopped before pregnancy. Most of the time, if you find them pregnant, just stop it. You don't have to do anything specific. To summarize, and time to go for dinner, a good effective way. And remember that a lot of us, we don't think about it because we think about GLP-1RAs as expensive. So the entire combination is the same as IDEC ASP. So a good option. Many patients can go from 2 to 3 doses to once daily doses, can go up with higher titrations and will work very, very well. Dr. Jabbar and Manoj are not here. If you still have questions, I'm happy to take it. And again, thank you for all of you for staying back to listen to this talk. I'll again see you for two more talks tomorrow. Thank you so much.
Thank you, Dr. Krishna Seshadri, sir, for that enlightening talk and showing us the importance of combining two agents with complementary mechanism of action. We can take few questions, if any.
Can you use the mic, sir?
It's only for suboptimally controlled with the patient or for generally all?
Sir, a GLP-1RA can be used any time in the whole this thing. So, for example, let's say somebody can't afford a higher dose of GLP-1RA, but they need a GLP-1RA for weight reduction, not using. Definitely, you can start off on either a single dose GLP-1RA, and then you can switch over to iGlarLixi when insulin is required. If a patient can take at least once injectable a day, it's a great way to do this. For example, I'll tell you what I do. SGLT2 inhibitor plus or minus metformin, maybe add a DPP4 inhibitor. If it doesn't work, I try to go off into something like this. And in many patients, instead of just starting on just Lantus or something, I start this because the overall dose is lower and I also get the benefit of combining a GLP-1RA with insulin. Because any day, a GLP-1RA inside the system today is a much, much better option than other things.
Probably other OADs except gliptins or oglibos.
Yes, sir. Absolutely. I would think if there are any indication for insulin, I would think a combination of a GLP-1RA with insulin is probably better.
Okay, thank you.
Thank you.
So with this, we are winding up the session. Thank you, speakers. Thank you, audience, for patiently listening.
Thank you. Thank you so much.
Thank you for wrapping up the day with practical, cutting-edge clinical insights. With that, we conclude day 1 of JPEF 2025 in Periyar Hall. Thank you for all the participants, moderators, and faculty for a deeply enriching day. As we reflect on today's theme, weight matters, let us come into acting early, acting wisely, and acting together.